Okay, and we are live. Hello, hello. Good evening.
Hello,
This is
Merritt.
Sarah Merritt. Hi. Talking tonight live for the first time in some time. So thanks for joining us wherever you are. This is Sarah Merritt from Lifestream Health Center in Bowie, Maryland, and I'm here with a special guest, Dr. Margaret Boltja of Georgia Interventional Pain. And I'd love to have her share a little bit about her practice. But first, I may tell you folks a little bit about what I know about Dr. Bolcha, and that includes that she has been trained in neurology, but also in interventional pain, which is a unique position that she has with a lot of knowledge of the nervous system. But then interventional pain training also, where she can do injections and procedures in addition to managing medications for pain. So welcome, Dr. Bolcha.
Thank you very much, Dr. Merritt. Thank you for having
Yeah,
me.
glad to have you here. Well, I just wanted to take this opportunity to chat and let you tell us a little bit about your practice. And I think that you have kind of a unique place in the pain care ecosystem, just with your knowledge of neurology and training in interventional pain. I'd love to have you tell us a little bit about even how you got interested in being a pain management doctor.
Well, I practice general neurology, which does involve a lot of pain, but it's just after some time, I really felt like I wanted to learn more and make some changes. So about 4 years ago, I started doing interventional pain. I was trained by a physiatrist, interventional pain physician in South Georgia, and learned how to do epidural injections, radio frequency ablations, started studying the fluoroscopy images, started doing ultrasound guided injections. And I just thought, oh my gosh, this is just awesome. I became very passionate about this because all of a sudden I was having such great results, and I really started enjoying the instant gratification I could get when I had a patient. I would do an injection, and they were like, "Oh my God, I feel so much better." So it was just been great, moving into that type of practice. So I actually also took an acupuncture course after I had dry needling done on my foot because I had a fracture of my distal tibia and fibula. And this is right before I made a change as well into the pain world. But when I was non-weight bearing for 3 months, I had a lot of pain issues and started doing dry needling. And I started thinking, oh, I really like this. This is so interesting. And then just started realizing just that doing Botox injections and having that other things to offer for my patients just was where I wanted to go. So
that's awesome. I love it that we're all, the joke, I guess, about medicine, right, is that we're always practicing. But I mean, there's truth to it, right? That we're always learning. Hopefully, if we're doing it right.
Always learning. I mean, it's been fun to not only be excited about looking at images on MRI of the brain and spinal canal, in the spine from when I was doing mainly neurology, and now learning the fluoroscopy, which is the X-ray stuff of the spine, and then ultrasound of all the nerves and muscles and ligaments. And so I love learning about it. It's just been, it's every day. It's just, I want to go and read, look at a book that has the images or watch a video on what I'm looking at. And so it's been really fun.
That's awesome. Well, and so when you're working with patients, tell me a little bit about that. So if you are seeing patients, you're taking new patients in your office. I checked out your website, and I know a little bit about your practice, just being that I have a similar type of practice. Tell me a little bit about what you have to offer for patients. And for instance, maybe one specific question would be, you see patients with acute pain problems and or chronic pain problems. One population of patients that you might see would be patients that have been in a car accident. How do you work with those patients to try to help them?
Well, in interventional pain, and practices, we look at the patient and try to figure out, is this something that would benefit from a steroid injection or just some type of numbing lidocaine or bupivacaine to help the person out. And so when you have car accidents, especially people who have some type of herniated disc or just a bulging disc that's not causing any problems, and when all of a sudden they have whiplash or some type of fall, doesn't have to be a car accident, then that's when it's great to be able to offer steroid injections to reduce the inflammation at right next to the inflamed nerve, next to the herniated disc. And that's just one example. People who are playing pickleball, who have injuries to their knees or other, tennis elbow, it's just nice to be able to use ultrasound guidance and, and inject a steroid and numbing medicine to see how it helps. And now there are people with chronic pain also benefit as well, but you just don't do too many steroid injections because of the benefits. And in that case, we also offer regenerative medicine, which is when you can offer platelet-rich plasma or mesenchymal stem cells from your bone marrow and have your own body heal. And it's a different process, but that's also so nice to be able to offer that, in addition to recommending therapy, physical therapy and rehab and everything. So everything works together to help heal and allow more function.
Yes. No, and I love it that you mentioned physical therapy and rehab, because I agree. Like that's, for most of us as physicians, that's like step one, for a person with an injury is, do some physical therapy, try some physical therapy initially, but then if that is not sufficient, then considering other things, including medication, injections, etc. Tell me about, I'm thinking about the ultrasound that you were mentioning. So if you're working with patients, you have an ultrasound in your office, or do you take patients to a procedure suite or to a surgery center for procedures? How do you do that?
We have an ultrasound in our office. So so we just, examine the patient and bring the ultrasound machine over.
Yeah.
See what
on the spot.
Yes, on the spot. And we also have a fluoroscopy machine in our office as well for injections that require that, such as any type of spine, neck pain and back pain, radiofrequency ablation, epidural injections.
Great. So you can do all those things in the office without going anyplace else. That's great. Yeah, so I think it might be worth, so I would tell you when I've had folks on my channel before and we've chatted about ways to help people with pain, it hasn't been very frequent that I've had another interventional pain doctor. So I would love to kind of almost like go through some of the bread and butter procedures that we do as interventional pain doctors and kind of talk about, what they are. Because for you and me, we get kind of used to, you've got some pain from your facet joints. Maybe we should do a medial branch block, and we just have some understanding of what that is. But to the patient who, may have an injury, may never have even heard of it before, we've got to hit the ground running and help them get up to speed to understand what's going on to get the benefit of the treatment.
That is so true. And sometimes when we're busy in clinic, it is so hard to remember all the details to explain to the patient so that they are aware. It's important to give out handouts so in case we miss something. But yes, one of the things that I think the more common thing people are aware of are lumbar and cervical epidural injections. And that is usually due to a herniated disc or some type of spur, osteoarthritic issue in their spine. And we basically go in and numb up after we're looking at the x-ray, numb up the area. It's with lidocaine and add a steroid to it and inject it next to it in a very safe manner using the fluoroscopy. So that is, it usually provides, depending on the patient, anywhere from I have patients who come back maybe once every 2 years when they have a flare up of and get one and they do fine. Some patients, this disease is much worse, and so the effect may not last as much. And the thing that I think a lot of people are not aware of is the facet joint disease. It's also, a lot of patients have both. And when the neck pain or back pain is worse with extension or turning your head or neck, there's not like a radiating pain down your arm or down your leg, then a different procedure is when we basically go in and numb up a little sensory nerve that innervates these joints that are arthritic. And that basically stops the signal from going to your brain to tell you you're in pain. So it's fascinating how it works. Actually, we don't actually get rid of the arthritis, but we're trying to help the quality of life for someone. And if it works, we end up doing the radio frequency ablation to actually destroy the little nerve, the little branch of sensory nerve, so that it can't send the signal back to the brain to say you're in pain. So it's fascinating to me.
Awesome. Sorry, I'm just hitting the layout button because I'm seeing if this is something that's going to let me share some slides. So we're going to dance around the screen for a second.
How would you add to that, Dr. Merritt? What's another good?
Yeah, I mean, I think those are the question I would ask too is the add-on question that patients give me all the time. Hey, I know about epidurals because I had one for labor, or my wife had one for labor. Is this the same thing? So that's like a super common question that we get as interventional pain docs. And what would you say about that?
Yeah, that's very true. And I would say that is a lot different and a lot more invasive. And so, yes, the epidural injection is more, it doesn't go into the space where you can, whereas the one with the labor, it affects you such you can't feel the birth process, but this is not as invasive. So that's what I tell my patients. And this is also to help a certain type of pain going down the leg or down the arm. So
yes, and I'll sometimes add also that kind of what's injected, and that for the labor epidural, there's actually a little tube that often goes into the spine, and there'll be a little flow of medication. And then there's less that we give, of course, in an in and out epidural injection, a little numbing medicine, and a little steroid medicine usually.
That's a good point.
Yeah.
That's a very good point.
I think that's probably the biggest question, and happens super super often, and sometimes I'll also tell people the epidural space, epi is like next to, and the dura is the leathery covering around the spinal cord and the nerves, so we're going kind of next to the nerves, not into the nerves.
That's true.
So some different ways to explain it. The other thing I'll sometimes do is, if I have, in most of my exam rooms, I'll have a spine model, and I may point at the spine model, and it's sometimes, if it's the spine model with the spinal cord stimulator, then there are already some leads, something kind of showing where that layer is. Yeah. So, hey, we're not doing anything with wires, but where this wire is, that's the spot.
Yes, that does help. Having the models definitely help.
Look at this. Here's my pain management. This is my procedure for my staff presentation. So so the one we were talking about a second ago was this facet injection or medial branch block. And it's really to numb up this joint. This is what Dr. Boltja was talking about. And just some graphics to show how placing a needle either in the joint, or more often actually kind of next to the joint where the pain nerves travel, can really help.
That is so true. And a lot of times, and especially in the neck, I mean, so many times this is contributing to headaches as well. So it's nice to be able to offer, that to my patients, instead of when I was previously, doing only neurology and only headaches. This allows me to put everything together a lot more thoroughly. So,
yes. Yeah, and we see that so commonly after car accidents. The headache, neck pain,
Mhm.
and or posterior headache so commonly. Since we were talking about that epidural steroid injection and that epidural space, so this is our graphic. For folks at home, this isn't like second nature to you to think about where these flares are. The epidural space is this kind of little gray zone here outside of the nerves, but just right next to them.
That's right.
And
Mm.
actually, oopsie, hang on. I clicked off my screen. Um, this other type of epidural, sometimes called a sensory nerve root block or a transforaminal epidural, is just a little bit different. Instead of a midline approach, it's from the side. Sorry, my graphics covering a little of that
Yeah, looks perfect.
verbiage there, but yeah, just that it's a procedure that can help with back and leg pain, most often with leg pain, but can help back too. Yeah, let's talk a little bit about the medial branch block and headache connection. Tell me about how do you get clued in for a patient who's complaining of some type of neck pain or headache, that it's a patient who might get benefit from a medial branch block or a radio frequency for that.
Well, before we do the radio frequency, we always have to make sure they respond to the block first, which is just the temporary numbing medicine before going through that. But on exam, if you're having headaches and they especially start in the back, and then you examine them and you find tenderness in the back, you could have any combination of myofascial pain, occipital neuralgia, facet joint pain. Sometimes it's very hard you might even have cervical dystonia that just would respond to Botox of the neck, causing the neck pain, and not even the facet joint. So you really have to take into your exam and what the MRI shows, and the description of the pain from the patient. And then once you try different things, it's definitely, it's rewarding to have that. Especially after you do the radio frequency ablation, because usually gives people relief from that type of pain for an average of 6 to 12 months. So it's so nice to be able to
Yeah,
have that. It's so
get
rewarding.
that long pain relief. Yeah, and I would say I've got a couple of folks in law enforcement in particular who've had multiple car accidents, and yes, they will sometimes have these headaches and posterior neck and
Mhm.
head pain, and come in for that periodic RFA, and it makes a big difference.
Mhm. And
We've
sometimes
actually got a question from the audience too here,
oh, cool.
Dr. Boltja. Is an epidural or an RFA treatment better for treating bad pain from a car accident? Do you have any thoughts on that?
My experience, it depends on what kind of pain. The ones who come in with severe neck pain that's usually radiating into their shoulder or their arm, and they come in and their arm is, they're abducting their shoulder, and it's much better with this. When they do this, it takes the pressure off the nerve.
That's the person with the herniated disc or
Yes,
whatever, right?
yes. It's shoulder abduction, makes it feel better. That's obvious. That's one of my favorite things to see, because that's
Yes.
usually the cervical epidural that's going to help that. And I've
it tells you.
yes, that is a lot of fun to get that. But not, and a lot of times people have multiple causes of pain, so you have to sometimes tease things out with the procedures.
Yes. Yeah, no, that makes a ton of sense. Yes, I would agree with that, that it really depends on that pain source. And so based on, usually the decision criteria of, what's the diagnosis? Is it a cervical radiculitis or cervical radiculopathy versus is it a facet-based pain, facetogenic pain? We're going to kind of make that diagnosis with the history and physical and the imaging. And so that physical part, that patient that tells you they're walking around like this, or when you ask them what things make them better and worse, those are the indication, and the person with radiating pain down the whole arm, those are some things that might lend you to believe a little more so that there's a bit more of a radicular pattern versus those patients with like pain with facet loading. So pain with looking at the ceiling, neck rotation in particular. Those are all things that would impact the movement of the facet joints and maybe implicate the facet joints a little bit more in the cause of the pain.
Very true.
Nice. Yeah.
Yes.
Yeah. Love it. Love it that we got a question.
Yeah, thanks for the question. Thank you for the question.
Yeah. Cool. Well, tell me a little bit about, I understand that you are starting to incorporate some of the newest cutting edge stuff in pain medicine. And Dr. Boltja and I've had conversations about this, but regenerative treatments like PRP and prolotherapy, that they're starting to incorporate some of those things into your practice. And I think that's super exciting. I would share that we're doing the same at my practice at Lifestream and Lifestream Health in Maryland. Just starting to incorporate that a little bit more into our treatment algorithm. Tell us more. Tell us more about how you're finding that in your practice.
Well, it is. I definitely think this field is growing, and people are starting to get more and more aware of this option. But it is regenerative or medicine, which is the most let's see, platelet-rich plasma, mesenchymal stem cells, which you can get from the adipose tissue or bone marrow. You get that from the patient who's having pain issues, and you spin it down in a centrifuge machine a couple of times, and you're basically concentrating the growth factors and all the things that help heal the type of pain. So depending on what part of the body, this is sort of definitely based on science, and but images have really been shown in many conferences of how this is very kind of complex, but it definitely helps with improving certain areas depending on where you put this, and everybody's getting different results. The evidence-based medicine that is best for this type of treatment is I believe knee osteoarthritis and lateral epicondylitis, and which is tennis elbow. So there's a lot of data that still needs to be done, but there's also a lot of anecdotal, and case reports, and people who are willing to go that route. There are people now that search out for that kind of treatment because they want to they don't want to keep getting steroid injections and that kind of thing.
Yes. Yeah, for sure. We're seeing that too, where patients are proactively looking out in that way. Or I've had a patient who was interested maybe in an injection, but was very concerned around steroids. And, we had some discussion around maybe a conventional pain procedure with local only. And then depending on the success of that, think about, a PRP or a regenerative injection of some sort.
That's definitely a great idea. First, it definitely is the way to get. I think that's a great way to do it, because it is expensive. It's cash pay. Most insurances do not cover it. So,
yes. And what are the targets? I mean, for regenerative treatment, can those be done kind of anywhere? Back, neck, peripheral joints.
It's interesting because, like I said, I think a lot of the orthopedic groups may be offering it for. I think knee is the most common, but I'm not totally sure about that.
I think that's right. Yeah.
It depends. There are different things. There's also something called A2M, alpha 2 microglobulin, which is better around nerves. And so I was talking to a neurologist who does a lot of this in California, and he does carpal tunnel injections using the alpha 2 microglobulin and hyaluronidase, and he puts it right there next to the nerve and the tendon, and
Mhm.
is having amazing results. People have been told they need surgery for carpal tunnel, and he's been having unbelievable results. He puts the hyaluronidase right next to the nerve, and the alpha 2 microglobulin. A lot of, so again, this is not, there are differences of opinions as to, whether you should do a lumbar epidural with PRP or the bone marrow aspirate. There are
Yeah.
different schools of thought as far as what goes next to nerves or muscles or ligaments and tendons. So it's
Mhm.
so takes some research on that first. So
Yeah, yeah, I would say we haven't offered that necessarily in the intraspinal in our practice yet, but I do think that is kind of a direction things are going. I my practice, I actually there was a doctor here long before me, Dr. Robert Lyles, and he had a PRP machine in the 2010s and was doing some PRP even then. And interestingly, like, even today in 2024, I will have some patients show up now and then that have had a PRP
interesting.
10 years ago from Dr. Lyles. Yeah. And a few of them have wanted facets.
Hmm.
And that's simple enough, to
Hmm.
get at the facet joint um, with the fluoroscope and then
Hmm.
applying the PRP
Hmm.
to those areas.
Yeah, I think that's a great option, especially in young people who have facet disease. Who,
Yes.
it's not the best idea to do the radio frequency ablation in a young person for that. I don't
Right.
think. So I always try to offer the PRP for something like that. I think it's you
Yeah.
know worth trying
Well,
that.
and just to put a fine point on it, what would the reason for that be? Why would a young person maybe want to lean a little bit more away from a radio frequency? Why would that be a negative for them?
Well, because there is a thought process that with when you do have the radio frequency ablation, that sometimes you can get atrophy of the muscles,
Mhm.
and that's why I think a lot of people sort of avoid that, and because I'm not really, obviously, if they're very physically fit and working out and that kind of thing, and keeping that as not an issue, that's good. But it's just one of the concerns people have.
Yes. Yes, yeah, and I think that's exactly it. Just the destructiveness of it, and
Mhm.
I think it can be appropriate in young patients. It's not never. Um, in seniors, we tend to do it and not really think
Yes.
twice about it. But for some of our young folks, right, if we can get around it, if we can get by without it, then that's often preferred.
Well,
Yeah.
and everybody has different approach of, different concerns. You go to an acupuncture course and, they're very,
Mhm.
very against, the steroids and the radio frequency ablation. Everybody's kind of got their own opinion about stuff. So everybody, you have to be kind of realizing who you're talking to and what kind of training they've had. So,
Yeah, yeah, that's right. Well, and it's all about risk benefit, right? So for me, as a physician, I'll tend to want to talk to my patients like, hey, our interests are aligned, right? I want you to get better. I want this to work. I'm not here to do something that you don't want to do or that you don't feel
right,
comfortable with. That's actually not helpful. And interestingly, like in the pain literature, if the patient doesn't believe that the procedure is going to be
right.
helpful for them, guess what? It's not going to be
That's
helpful.
true.
And we have real like science for that, and I think it just makes intuitive sense. So, the patient needs to be fully on board. Um, but yeah, I think for patients who are at a point of considering an interventional procedure, yeah, it's very reasonable to try lower invasiveness things first. So PT, dry
Mm.
needling, acupuncture, all those things. And if those things haven't gotten you where you need to be, then there are other things, but they
Mhm.
maybe aren't the first thing.
Yes, I agree completely.
Yeah, nice.
Mhm.
Um, cool. Well, I think you've answered all my questions here, Dr. Bolcha. Is there anything else that you want to share with us or anything else you think we should talk about this evening?
Well, no, I just want to say thank you so much for taking the
Oh, yeah.
time and inviting me to your show.
Of course, of course. Well, I'm glad to have you. I'm glad that we could talk a little shop here with some anatomy even. It's kind of fun. I don't
Mhm.
usually do that,
Absolutely.
but I
Very
think I could imagine doing even like a deep dive on individual procedures, right? That we could probably, talk through some of those and end up with some good recordings to share with people.
well,
Awesome.
thank you very
Well,
much.
thank you so much for being here. Yeah, I'm going to wrap it up here and leave y'all to your evening. This is Sarah Merritt with Lifestream Health Center in Bowie, Maryland. We're working to make pain management more caring and accessible, patient-centric, and evidence-based. And we are taking new patients. Come find us. You can find us at lifestreamhealth.com. And also, our phone is 301 860 0305. Good night.
Good night. Thank you.